is a burning thing.
Hi guys, thanks for coming today to this great new program that we have offered here at County Hospital. We are really trying to stop smoking to our young women population, and I'm just so excited that you guys are into this. I wanted to talk to you guys about this awesome new app we can use with our patients to give them better recommendations and materials to help them quit smoking. Basically, it breaks down the recommendations into various grading scales, and we can use that to determine which of our patient populations needs what kind of recommendation. Since our new campaign is targeting women aged 8 to 22 in our low-income community, this would be a great way for our patients in the new techie age to kind of see what's going on with them. We want our patients who already smoke to know the facts and also have the tools to be able to quit. Smoking cessation is always a grade A. When our patients tell us they smoke, it's also a grade A for pregnant women, regardless if they tell us whether they smoke or not. With the grade A, the USPSTF, which is the United States Preventative Service Task Force, recommends that clinicians ask all adults about tobacco use and provide smoking cessation interventions for those who use tobacco products, regardless if it's cigarettes or electronic cigarettes or things like that. This recommendation applies to all adults over 18 and all pregnant women, like I said, regardless of age. And the USPS Task Force plans to issue separate recommendation statements about counseling to prevent tobacco use in non-pregnant adolescents and children, but those haven't come out yet. As you may know, cigarette smoking is the leading preventable cause of death in the United States, and it results in more than 400,000 deaths annually from cardiovascular disease, respiratory disease, and cancers. In addition, smoking during pregnancy results in the deaths of about 1,000 infants annually and is associated with an increased risk for premature birth and low birth weight. Environmental tobacco smoke contributes to an estimated 38,000 people annually, which is a huge number, and we need to use our program to help these women quit and be aware of how dangerous it is for them and the people around them. Some of the tools we can use are the 5 A's behavioral counseling framework, and counseling and interventions are the best ways to prevent tobacco use and start cessation if they already smoke. We initially need to ask about the tobacco use because we need to know whether they smoke or not, advise them to quit and why they couldn't quit, and assess their willingness to quit. So we need to kind of gauge what the best course of action would be if they do smoke. We need to assist them. We can't just give them information and lead them on their way. We need to actually help them and sit down with them and create a plan. And we need to arrange for follow-up and support regardless of what that be, whether it's the quit line or medication or things like that. To start treatment, we would use a combination therapy with counseling and medications if they're willing to use the medications, which is the more effective at increasing cessation rate other than just one of the components alone. There is a direct dose-response relationship between quit rates and the intensity of counseling, so we need to start early and continue treatment to have the best rates of success.
22-year-old females, they're very vulnerable both for smoking but also for interventions to help them quit. There's a lot of new theories out there, I know, that have been implemented into helping with cessation and screening for these patients. I know you know a lot about it in your research. You were telling me it's like the health belief model. Is that exactly? What are the concepts behind that?
So recently we just went to a conference and we learned about the health belief model. And since we're focusing on females aged 18 to 22 in lower income communities who need assistance with smoking cessation, we looked at the health belief model, and this has been shown in research to be very effective for physicians to use and CNLs to use in helping these women. So there are 6 key constructs that we need to focus on. The first one is perceived susceptibility, and this is where you want to talk to your patient about the possible risk for developing a possible cancer, such as lung cancer, or even infertility for these patients who are younger, and that may be of concern for them. You also want to encourage or engage them, and by doing this, by giving them risk of developing diseases, this is going to engage the patient and make them aware of the risks of smoking. So then the next, perceived, is severity. And so this is where you want to discuss the severity of the health issue and its potential consequences. So an example of this for this age group could be infertility, like I discussed before, or a decrease in the effect of birth control. So a lot of times smoking will stop or decrease birth control, and this can be a great concern for these patients at this age. The next perceived is benefits. So this is the step where you will assess your patient and their beliefs in the efficacy and advise actions for smoking cessation. And this is going to reduce the possible health risks. So here you want to define clear steps that need to be taken and the positive effect that can be expected. So say for instance you're talking to an 18-year-old female who plays soccer. A benefit of smoking cessation would be that you would have positive respiratory function and cardiovascular function. Next, you want to talk about their perceived barriers. So you want to talk about the barriers or obstacles that the patient may encounter for smoking cessation. So in order for behavior change to take place, the benefits need to outweigh the barriers. So if they see that there is a minimal expense on their part, then maximal benefits is most likely going to have a behavior change, or you're going to see a behavior change. So next is cues to action. So here is where you will create strategies to activate the readiness to quit. So you can provide the patient with how-to material like pamphlets, support line systems, phone calls, anything like that. You can also identify triggers that lead to smoking, like environments or social setting, or their emotions, like what causes them to smoke.
Super important.
Yeah, and then the last one is self-efficacy. So this refers to an individual's perception of their ability to successfully quit smoking. So you need to determine this, where they're at, and then as a CNL you can provide goals for the patient, verbal reinforcements, and then tell the patient that taking small steps is perfectly okay. They're not going to, just quit right away and everything's going to be fine. So this, like I said, this model has been well researched and been shown to be.
Thank you so much, Erica and Natasha, for all your help with this seminar. This has been really interesting. And although the focus of today's conference is on tobacco use and cessation interventions in low socioeconomic populations, I'd like to start by focusing on smoking and healthcare providers. So as some of you may not know, 20.55% of licensed practical nurses, 10.73% of registered nurses, and 2.31% of doctors are current smokers. It is estimated that approximately 250,000 registered nurses still smoke in the U.S. And only 4 healthcare professional groups, being dentists, physicians, pharmacists, and registered nurses, met the Healthy People 2010 goal of a 12% smoking prevalence. Smoking among healthcare professionals is important in one way in that it serves as a barrier to intervening with patient tobacco cessation. Healthcare professionals need to serve as tobacco-free role models. Here at USC County, we are going to poll healthcare professionals on whether or not they smoke, and for those that do smoke, we're going to provide cessation resources and services to help them stop. Another thing that I would like to implement here is a series of mandatory continuing education seminars for healthcare personnel. These seminars will focus on the health effects of tobacco, tobacco control policies, evidence-based strategies for tobacco dependence treatment, and specific strategies that have been shown to be effective with low socioeconomic populations. Each unit in the hospital will be responsible for one seminar, meaning that they will provide all the information for it and ensure that all members of the team or unit participate. This will provide ample opportunities to ensure competency in tobacco control and cessation interventions. And moving forward, I think Mackenzie is going to help us sort of go into more detail about healthcare professionals and educating them, specifically doctors, RNs, and I think that moving forward is really the most important tool we have.
Thank you, Gabby. Yeah, so the most important step here for us as healthcare providers and CNLs really is education. And then, of course, we have the question, how are we going to get healthcare providers to implement these screening recommendations into practice? We know they're grade A recommendations. We know we need to screen all of these adults. So these women, 18 to 22, they should all be getting screened for smoking habits. But how do we implement it? How do we get people to do it? So, I mean, it starts off easy. It starts just from, providing training and technology training. And then, our main struggle and obstacle that we see with physicians in particular, especially in hospitals and fast-paced, high-movement medical facilities, is timing. They think it might be out of context, or they don't have time to, sit and have a chat about smoking when they're here for a different reason. But it takes very little time, and we know as healthcare providers how important it is for our patients. So, the technology, it's completely cost-free to the CNL, to the provider, to the patient. For these quit lines, you can refer them to these toll-free quit lines, to help them with anything. The physicians themselves, what we're doing now, we can do during rounding, we can do during our lunch breaks, just sit and talk and educate them on how these providers can screen and just have conversations, really nothing more than a casual conversation about their smoking habits and how to quit and where to go for advice and for help. It's really a behavioral change thing. That's where the health belief model comes in. All these perceived, I can't do it, or I'm too young, it won't affect me now, I can quit down the line. And we need to really educate both the patients and our fellow providers on, it is important. We can educate them on motivational interviewing. So there's the 5 R's there. So the relevance, the risks, the rewards, the roadblocks, and then repetition. Each and every time you see this patient, discussing these options with them, And, there's simple, easy, you can provide, we as CNLs, we can provide brochures and pamphlets for these doctors to just give to their patients and let the patients read through. A lot of them don't know that they're at a high risk. A lot of them don't know that they have options to help them quit. They're not alone on this. And a lot of them are fearful of medication. It doesn't have to be a medication. It's just something as simple as a phone call, which for these vulnerable women could help in multiple aspects of their life, having someone to call. And then, there's a lot of, we have these screening, there's a lot of societal or environmental barriers kind of. The current screening is just to talk to everyone. But, it's hard. These women are young. They're in low socioeconomic places. Their boyfriends smoke, their parents, their friends, their peers. They're at an age where they want to maybe go out and drink alcohol, which also we know has an effect on their smoking trends and their inability to quit, or their desire not to quit for that matter. But most smokers do want to quit, and so it's up to us to educate the healthcare providers and our patients on how these options that they have. So really we can use their youth and their knowledge of technology to our advantage, spread the word, whether it's Facebook or anything of that nature as well, to really just kind of help them and to screen and make everyone more knowledgeable about the ability to quit and why they should.
This CNL conference that we just attended has been so informative about smoking and the guidelines and the screenings for smoking cessation. Let me just tell you about a few of the things. So the prevalence of smoking in people under the poverty line is actually pretty astounding. It's almost 28% of smokers are under the poverty line, and where if you compare it to people above the poverty line, it's only 17%. Another interesting fact that I learned today was that education-wise, if you have a graduate degree, only 6% of smokers have a graduate degree, but if you haven't even graduated from high school, you have, it's almost 25% of smokers haven't graduated from high school. It's impressive. So, a few other things we learned today are the risks that are involved in screening for smoking cessation, and the great part about that is that there is absolutely no risk in healthcare providers screening for smoking cessation in their patients. So we want to get the word out and screen pretty much everyone over the age of 18 and any pregnant women. Lastly was discussed was like the limitations or the controversies surrounding the screenings for smoking cessation, and I would say the most limiting thing is the health insurance companies only pay doctors for one visit for about 15 minutes, and it's been shown in studies that it will take up to 90 minutes of counseling with a smoker to actually have a successful quit rates.
Wow.
So we need to really work on that in our system.
Absolutely. Thank you so much for recapping that for me.
You're welcome.